Hello. Namaste to all the lovely doctors. A wonderful good afternoon to all the great doctors of this country. And here comes the oncosurgery story. In oncosurgery, we'll be discussing broadly about all the cancers in the body first. And this conceptual class, this will remain in the application till your exams. Right. We'll be studying about the GI cancers, the urinary cancers, the thyroid cancer, and the breast cancer. In the GI cancers, we'll be going right from the mouth up to the anus, including the oral, the esophageal, the stomach, the colorectal anal cancers, along with this gallbladder and pancreatic cancers, plus some other tumors like GIST, gastrinoma, carcinoid tumors, and so on. Urinary cancers, we'll be talking about kidney, bladder cancers. Then we'll be talking about prostate, penile, and testicular cancers, and thyroid cancers and breast cancers. How we are going to study all these different cancers? First, we'll see what is the type of cancer in a particular area, what is the site of cancer in that particular area, what are the risk factors for that cancer, how pathologically the cancer can grow, how the patient can present to us, how the cancer can spread in different areas of the body, and then depending on the presentation of the patient, how you, the great doctors of this country, have to approach in the management. Like what should be your next step depending on how the patient is presenting. So next step like this. Then what should be the investigation of choice to diagnose the cancer, investigation of choice to stage the cancer, and investigation of choice for metastasis. Once we'll completing all the investigations, then we'll do staging of the cancers. And then we'll come to know, okay, whether it is an early stage cancer or advanced stage cancer or maybe a metastatic cancer. And based on the stage of the cancer, we will be offering different treatment options to the patient, whether surgery, chemo, radio, hormonal, targeted, XYZ, right? So conceptually we'll go and we'll try to discuss. Like first, what is the type of cancer? So all the exposed areas in the body, they require protection. And for protection, God has given us squamous lining. So all the exposed area in the body will be having squamous cell carcinoma, except this particular area where we find basal cell carcinomas, which is discussed in your dermatology classes. Area near all the natural openings in the body, शरीर के जितने भी छेद हैं उनके पास में, they also require protection. So there also it is squamous lining. So we find squamous cell carcinomas. All the areas in the body where there are glands, that means where there are some secretions. So these glands, if malignancy has to develop in these areas, because there would be columnar lining, so there will be adenocarcinomas. Adeno is gland story. Urinary tract, from pelvic calyceal system, ureter, bladder, urethra, where there are no secretions, it is just a tract for the passage, is lined by transitional epithelium. So we'll find transitional cell carcinomas there. That means, if we have to summarize, first starting with GIT, area near natural openings of the body will be squamous. So oral will be squamous. Because we use this mouth very commonly, so God has extended the squamous lining from the oral cavity pharynx up to the gastroesophageal junction, just proximal to the gastroesophageal junction. That means malignancy in the oral cavity pharynx esophagus will be squamous. When this squamous lining changes to columnar from just above the gastroesophageal junction, the game becomes columnar in the stomach, duodenum, jejunum, ileum, cecum, ascending, transverse, descending, sigmoid, rectum, anal canal. So in the anal canal right up to the dentate line, From the stomach to the dentate line of the anal canal, there will be adenocarcinomas. In the anal canal, the columnar lining will change to squamous again. So, in the distal part of the anal canal below the dentate line, just above the anal opening, it will be squamous. So, squamous cell carcinoma. If we just focus on the anal canal, above the line is adeno, below the line is squamous. Most common is squamous. So, anal cancers most commonly are squamous cell carcinomas. Now, gallbladder, pancreas, there would be secretions, so there will be adenocarcinomas. In the urinary tract, the outer portion of the kidney is having the nephrons, so we find adenocarcinomas there. And then from the minor calyx, major calyx, renal pelvis, ureter, bladder and urethra, it is just a passage, so we find transitional cell carcinomas. In the distal urethra, that means area near the natural opening, the lining will change to squamous. So distal urethra will be squamous. Prostate is a gland, adenocarcinoma. Penis is outside, squamous cell carcinoma. Testis, germ cell tumors in testis and ovaries. Germ cell tumors in testis can be seminomatous, non-seminomatous, most commonly seminomatous seminomas. Thyroid gland. There are follicular cells in the thyroid gland and there are some parafollicular C cells also in the thyroid gland. Majority of malignancies arise from the follicle, leading to either a papillary thyroid cancer or follicular thyroid cancer. Malignancy from the parafollicular C cells is medullary thyroid cancer. In the breast, there are duct, lobule and stroma. Malignancy from the duct lobule will be carcinoma cancer, but malignancy from the stroma will be sarcoma. So, cancer of the breast or carcinoma breast is either from the duct or the lobule, 90% from the duct, that is invasive ductal carcinoma, and breast is also a gland, so it is adenocarcinoma. Right. Now, if I summarize once again, oral, pharynx, esophagus, squamous, stomach, duodenum, jejunum, ileum, colon, rectum, adeno, anal canal, squamous, gallbladder, pancreas, adeno, kidney, adenocarcinoma, bladder, transitional cell carcinoma, prostate, adeno, penis, squamous, testis, seminoma, thyroid, papillary thyroid cancer is the most common, breast, invasive ductal adenocarcinoma. Once more, oral, squamous, esophagus, squamous, stomach, duodenum, jejunum, ileum, colon, rectum, adeno, anal, squamous, gallbladder, pancreas, adeno, kidney, adeno, bladder, transitional, prostate, adeno, penis, squamous, testis, seminoma, thyroid, papillary, breast, invasive ductal adenocarcinoma. So this is regarding the type of cancer. Now, what is the site of cancer in these areas? All the great doctors of this country watching this session, whenever a carcinogen is coming in contact with the mucosa for a long period of time, then that mucosa will try to protect itself, and in order to protect itself, it will undergo rapid mitotic changes leading to cancer. That means that area which will be exposed to the carcinogens for a longer period of time, that should be the site of cancer. Like in oral cancer, we know the reason is tobacco. If somebody is taking the tobacco like this, then the buccal mucosa. If somebody is taking the tobacco like this and putting it here, then it is the gingivo-buccal sulcus. Gingivo-buccal sulcus. Western countries, smoking, so it is the lateral border of the tongue in the middle 1/3. Esophagus, upper 2/3 of esophagus is the common site. In upper 2/3, middle 1/3 will be more common. So overall it is upper two-third, but in upper two-third, if you have to choose between upper one-third and middle one-third, then it is middle one-third. However, Western countries, the esophageal cancer is related to reflux, and because of reflux, it is the lower one-third of esophagus which gets damaged, and we know there is Barrett's esophagus, so there will be adenocarcinoma in the esophagus, which will be more common as far as Western countries are concerned for esophageal cancer, and that will be adenocarcinoma. Stomach, the commonest culprit in the developing world, like in India, would be the pre-pyloric region, and it is the bacteria which is responsible for this. So it is the pre-pyloric region which is the commonest site. But in Western countries, stomach cancers are again related to reflux. So the area near the GE junction, that is the cardia of the stomach, will be a common site. Duodenum, jejunum, ileum. We generally don't talk about cancers because there is continuous peristalsis going on in duodenum, jejunum and ileum. So the carcinogens are not able to stay in this. And these carcinogens travel into the cecum, the large intestine. Yes, there the fecal matter would be staying for a longer period of time. And if we look at cecum, ascending, transverse, descending, sigmoid and rectum, the biggest reservoir would be rectum and the sigmoid. That is why carcinogens will be staying for the maximum duration in the rectum and the sigmoid. So 38% of colorectal cancers in the rectum, 21% in the sigmoid colon. That means 38 plus 21, 59% of colorectal cancers occur in the rectosigmoid area. Anal cancers are related to human papilloma virus, and this HPV is known to cause cancers near all the natural openings in the body. शरीर के जितने भी छेद हैं उनके पास में ये कैंसर करना है, ये HPV उनके पास में कैंसर करता है. We know HPV is the culprit for cervical cancer. It is also the culprit for the urethral cancer, the anal cancer, the oral cancer, the esophageal cancer. So cancers in the anal canal are near the anal opening, that is the anal purge. Gallbladder cancers, they are related to stone, and if we look at the topmost part of the gallbladder, that is the fundus. So stone may get impacted in the fundus, irritation of the fundus for a long period. Fundus is the commonest site for gallbladder cancer. Pancreas, we can find cancers in the head of the pancreas and in periampullary. Head of pancreas is the most common pancreatic cancer. Kidney cancers most often are seen in the proximal convoluted tubule, PCT. We are talking about the nephrons. Bladder, wherever the urine is staying in the bladder for a long period of time, like the lateral bladder wall and the trigone area. Trigone is a triangular area between the two ureteric openings and the bladder neck. So cancers are seen in the lateral bladder wall and the trigone in the bladder. Prostate cancers are common in the peripheral zone, posterior lobe. Penile cancers, the commonest reason for penile cancer is poor hygiene. Those individuals who do not clean their glands on a regular basis, they suffer from cancers at the glans or the prepuce. So glans, prepuce is the commonest site. Testis, anywhere. Thyroid, anywhere. Breast, upper outer quadrant. I repeat, oral, gingivobuccal sulcus and the buccal mucosa. Western countries, lateral border of the tongue, middle one-third. Esophagus, upper two-third, in upper two-third, middle one-third. Western countries, lower esophagus, adenocarcinoma. Stomach cancer, pre-pyloric. Western countries, cardia. Colorectal, rectosigmoid. Anal, anal verge. Gallbladder, fundus. Pancreas, head of pancreas. Kidney, PCT. Bladder, lateral bladder wall and trigone. Prostate, peripheral zone, posterior lobe. Penis, glans, prepuce. And testis, anywhere. Thyroid, anywhere. Breast, upper outer quadrant. Right. So this is about the site of cancer in different areas of the body. Now, the risk factors. One thing which we all know about cancers, maybe genetic story we might have inherited from our forefathers, or we might uh, have been exposed to various environmental factors, various risk factors. For example, the lifestyle of a person. A person who is chewing the tobacco will always be having more risk of developing this oral cancer. Smoking, we know, is the culprit for so many cancers. So we need to figure out that what particular factor can be irritative for long term in a particular area. Like oral, we know it is the tobacco story. Esophageal cancers, they might be related to uh, smoking, alcohol, smoked food, barbecue food, that black tar on the tandoori food, which is quite tasty. Now, if that black tar is being consumed on a very frequent basis, then definitely it is going to irritate the esophageal, the gastric mucosa, will increase the risk of cancer. Apart from this, Ecclesia cardia, Zenker's diverticulum, GERD, Barrett's esophagus, radiation exposure, human papillomavirus, tylosis. Tylosis is a condition where there is thickening of the skin, thickening of the tissues. Tylosis palmaris and tylosis plantaris. Suppose there is thickening of the esophageal wall. This will create some traffic jam, and traffic jam will create stasis. Long-term stasis will lead to cancer. And one syndrome in esophageal cancer, Plummer-Vinson syndrome or Peterson-Brown-Kelly syndrome. Three things in this syndrome: iron deficiency, glossitis, esophageal webs. This is commonly seen in middle-aged females. Esophageal webs, they might create a traffic jam in the cervical esophagus, that is that portion of the esophagus which is in the neck, and that may cause stasis and cancer, squamous cell carcinoma in the post-cricoid region. Stomach cancers, again, smoking, alcohol, smoked food, canned foods which have got preservatives like N-nitrosamines. People who are taking more spicy food, more salt, more pickle, people who take less vitamins, antioxidants in diet. We know our elders our parents keep on telling us, eat healthy food, eat healthy food, eat healthy food, take lots of fruits, take lots of vegetables. Why? Because these fruits, vegetables have got vitamins, antioxidants, and if we are taking good amount of vitamins, antioxidants, then this makes our mucosa strong. And if your mucosa is strong, then it cannot be easily acted upon by the carcinogens, and the chances of cancer would be less. But if somebody is taking less vitamins, antioxidants, yes, any mucosa anywhere in the body will be exposed to those carcinogens, will be more vulnerable for cancers. Apart from this, stomach cancers, Helicobacter pylori, various pathologies, gastritis, any chronic gastritis, type A, which is autoimmune atrophic gastritis, type B, related to bacteria, Meniere's disease, where there is gross hypertrophy of mucosal folds, reflux gastritis. Any patient who has undergone gastric surgery, if we remove the distal part of the stomach and we are connecting the stomach with the jejunum, the alkaline secretions from jejunum will reflux into the stomach, will cause alkaline gastritis in the stomach, and then the stomach mucosa will like to become as jejunal mucosa, so there will be intestinal metaplasia in the stomach, and this will lead to stomach cancer. So patients who have undergone any previous gastric surgery, any damage to the pyloric sphincter, high chances of gastric cancer. Gastric ulcer should be considered as malignant unless proven otherwise. Adenomatous polyps in the stomach can lead to gastric cancer, and mutations in various genes, P53, SMARCA, ROA genes, all this can lead to stomach cancer. Colorectal cancer, People who take more amount of red meat, lal mass, they have more chances of colorectal cancer. Animal fat, more consumption of animal fat, increased risk of colorectal cancer. Less fiber in diet, people will be constipated. And in constipated individuals, the carcinogens will be staying in the rectum sigmoid for a long period of time. Less vitamins, antioxidants in diet, mutations in the APC gene. If we look at the various pathologies like inflammatory bowel diseases, ulcerative colitis will have more risk of colorectal cancer. Cholecystectomy increases the risk of colorectal cancer. If we remove the gallbladder, the bile salt bile acids are not getting stored. So from the liver, the bile salt bile acid is coming directly from the bile ducts into the duodenum, and they would be staying for a longer period in the rectosigmoid area. Also, if gallbladder is not there, fat digestion can be a problem, especially if the patient takes a bulky fatty meal. So more fat exposure in the rectosigmoid area can lead to these cancers. Radiation exposure can lead to colorectal cancers. Various polyp conditions, various syndromes like familial adenomatous polyposis, where there are more than 100 adenomatous polyps in the colon, which can be associated with Gardner's syndrome and Turcot syndrome. Hereditary non-polyposis colorectal cancers, all these can be associated with colorectal cancer. Anal cancers, human papillomavirus, gallbladder cancers, gallstones, typhoid carriers. If salmonella stays in the gallbladder for a long period of time, chronic irritation can lead to cancer. Porcelain gallbladder, calcium deposition in the gallbladder can increase the risk of gallbladder cancer. And adenomatous polyp in the gallbladder, if it is more than 10 millimeter in size, the chances of cancer will be high. Pancreatic cancers related to smoking, chronic pancreatitis, hereditary diabetes mellitus. Kidney and bladder cancers, the most important culprit is smoking, because in smokers, the toxins, they are going through the circulation and are getting excreted through the urinary tract, and the urinary mucosa is getting exposed to these toxins very frequently. And there is a possibility a day comes when this urinary mucosa wants to protect itself and undergoes rapid mitotic changes. Kidney and bladder cancers are also called as occupational cancers, industrial cancers. People who are working in industries which have more dyes, chemical type of exposure. Life of a painter, carpenter, shoe polish worker. वो जो जूते पॉलिश करने वाले भैया हैं, दिन भर जूते पॉलिश करके अपना और अपने परिवार का पेट भरते हैं. अगर कभी उनके पास बैठो, उनके हाथ को देखो, उनके हाथ काले हैं. सुबह से रात तक पॉलिश करके जो केमिकल्स हैं पॉलिश में, वो केमिकल्स उनके सर्कुलेशन में एब्जॉर्ब हुए और वहां से ये केमिकल्स उनके यूरिनरी म्यूकोसा में पहुंचे और यूरिनरी म्यूकोसा को इरिटेट करके कैंसर तक बना देते हैं. बेसिकली shoe polish worker example, if the shoe polish bhaiya, he is earning bread and butter for his family by polishing the shoes, the chemicals in the polish is getting absorbed into the circulation, and through the circulation getting excreted through the urinary tract, exposing the urinary mucosa, leading to cancers. Kidney cancers are associated with long-standing stones in the kidney, long-term analgesic abuse, von Hippel-Lindau syndrome, VHL, associated with 3P. So that can be associated with kidney cancer. Prostate cancer. Prostate cancer, cancer के नाम पे कलंक है. Prostate cancer is a very slow growing cancer. And it is believed that if God gives us the age above 80 years of age, then more than 70% of males suffer from prostate cancer. And probably, as we see in BPH, after 60 years of age, because of overactivity of 5-alpha reductase, there is increased conversion of testosterone to 1,5-dihydrotestosterone. and probably that is causing that hyperplasia. And if it continues for a long period of time, or maybe after 8 years of age, there is more conversion which can lead to cancer. Exact cause is not known, but thought to be androgen age related story. Penile cancer, poor hygiene. Those boys who do not clean their glands on regular basis. This is the most important reason for penile cancer. However, for penile cancers, human papilloma virus, long-standing genital warts, various pre-malignant lesions, erythroplasia of Curat, Bowen's disease, multiple sexual partners is a risk factor for penile cancer. Smoking, testicular cancer. Most common cause of testicular cancer is undescended testes. Thyroid cancers, papillary thyroid cancers are associated with radiation exposure, especially if multiple X-rays or CT scans of the neck have been done in a younger age, say less than 5 years of age, then the chances of papillary thyroid cancer are higher later in life. Thyroglossal cyst, because of stasis of secretions here, can lead to papillary thyroid cancer. While follicular thyroid cancer is commonly associated with long-standing endemic goiter. Breast cancer, genetic stories, BRCA1, BRCA2 genes, both BRCA1, BRCA2, BRCA1, BRCA2 genes, breast cancer genes. Mutation in both can be associated with female breast cancer, but only BRCA2 gene mutation is associated with male breast cancer. We know breast cancer is familial also, and it is not only the maternal side but also the paternal side. Familial story means if the mother had breast cancer, mother's mother had breast cancer, mother's sister had breast cancer, own sister had breast cancer, or she herself had cancer in one of the breasts, then chances of cancer in the other breast are high. And not only mama's side, papa's side. If father's mother had breast cancer, father's sister had breast cancer, then also breast cancer in the daughter, chances are more. यानी breast cancer में सिर्फ मम्मा की साइड की फैमिली इज नॉट द कल्प्रिट, पप्पा की साइड की फैमिली इज ऑल्सो द कल्प्रिट. अगर मम्मा को ब्रेस्ट कैंसर था, मम्मा की मम्मा को, नानी को ब्रेस्ट कैंसर था, मम्मा सिस्टर मौसी को ब्रेस्ट कैंसर था, अगर खुद की बहन को ब्रेस्ट कैंसर था, खुद को एक ब्रेस्ट में कैंसर था, दूसरे ब्रेस्ट में कैंसर होने का चांस ज़्यादा है. और पप्पा की साइड भी अगर दादी को ब्रेस्ट कैंसर था, बुआ को ब्रेस्ट कैंसर था, then also. Not only this, breast cancer is also related to hormonal story. Any female who is exposed to more of estrogens during her lifetime, for example, early menarche, late menopause. Suppose the menses started at 10 years of age and menopause achieved at 50 years of age. Duration of exposure, 40 years. Another girl, menarche 15, menopause 45, 30-year exposure. A female who was exposed for 40 years will have more chances of breast cancer. That is why nulliparous female, more chances. Postmenopausal obese female, after menopause, if the lady is obese, then because of aromatization, there is increased conversion of the body fat into estrogen. So even after menopause, the lady is getting exposed to estrogens. After menopause, if the lady wants to take hormone replacement therapy, then she is exposing herself to more of estrogens even after menopause. OCPs, oral contraceptive pills, are not generally associated with increased risk of breast cancer, but if somebody is taking high estrogen content OCP for a long period of time, yes, this can increase the risk. Consumption of less phytoestrogens in diet can increase the risk. Phytoestrogens, they are good estrogens. They are present in beans and pulses. जो लड़कियां दाल और बीन्स ज़्यादा खाती हैं उनमें ब्रेस्ट कैंसर होने का खतरा थोड़ा कम रहता है, क्योंकि इन बीन्स और दालों में फाइटोइस्ट्रोजेंस होते हैं। अगर फाइटोइस्ट्रोजेंस आप ले रहे हैं तो ये फाइटोइस्ट्रोजेंस ब्रेस्ट के सेल्स पे जो ईस्ट्रोजन के रिसेप्टर्स हैं उनसे जाकर अटैच हो जाते हैं, और जो उस लड़की के खुद के ईस्ट्रोजेंस हैं वो ब्रेस्ट के सेल्स पे एक्ट नहीं कर पाते। The phytoestrogens are good estrogens in beans and pulses. If a girl is taking good amount of beans and pulses, then the phytoestrogens will go to the estrogen receptors in the breast, and they will not allow the girl's own endogenous estrogens to act on the breast cells, thus decreasing the risk of breast cancer. That means protective factors for breast cancer can be late menarche, early menopause, multiparity, prolonged breastfeeding, and having first child at an early age is also protective. अगर पहला बच्चा जल्दी कर लो तो ब्रेस्ट कैंसर होने का खतरा कम होता है. Do not get motivated. So these are the different risk factors for all the cancers. Pathologically, the cancer can either grow as an ulcer, or maybe as a polyp, or maybe as a growth. For example, there might be a patient who is having an ulcer in the oral cavity and he is giving you a history that this ulcer is present for the last 2 to 3 months and I have tried everything and this ulcer is not healing. Might be a cancer, need evaluation. Growth. There might be a irregular growth in the oral cavity. Esophageal cancers, they grow as a polyp and they cause a traffic jam, dysphagia type of stories. How the patients will present to us. Oral cancer, patient will come to us, yes sir, there is something here, maybe an ulcer or maybe a growth. Esophageal cancer, dysphagia story. Stomach cancers, maybe epigastric mass, or as we know, all the cancers, it is not only the growth of the mitotic cells, it is also the growth of the blood vessels. So chances of blood vessels getting injured leading to bleeding will be high. And if the stomach cancer bleed, blood in the stomach can go out either as hematomasis or it can come out as melena. Colorectal cancers, rectal cancer, sigmoid colon cancers, most commonly rectal cancers present with bleeding per rectum. Anal verge cancer. Just like a patient of oral cancer came to us, doctor, there is something here. Anal cancer patient will come to us, doctor, there is something here. For mass at the anal verge. Gallbladder cancers may present with symptoms of cholecystitis, or sometimes maybe a right hypochondrial mass, or if the cancer has gone into the liver, maybe jaundice. Pancreatic cancers, whether it is the head of pancreas or periampullary, this will put pressure on the bile duct, and if the bile duct is pressed, then patient will present with jaundice. So pancreatic cancers will present with jaundice. Kidney and bladder cancers, painless hematuria. Prostate cancer, no problems. Patient does not know that he is having a cancer. By the time patient develops symptoms, the cancer would have advanced. And if the cancer has gone into the lumbar vertebra, prostate cancer, then patient may come to us with low backache. And when we take a X-ray in these patients, we see, oh my God, there are metastases in the vertebra. Penile cancer, just like oral cancer was presented like this, anal verge cancer presented like this, same way penile cancer patient will present like this. Testicular cancer, tumor in the testis, scrotal enlargement, heaviness in the scrotum. thyroid cancer, swelling in the neck, breast cancer, lump in the upper outer quadrant of the breast, and cancerous lumps, they will be hard, irregular, may be fixed to the underlying or the overlying structures, may be involving the lymph nodes or the nerves. So if the lymph nodes are involved, if the axillary lymph nodes are blocked, then lymph from the upper limb might not be going there. So there might be lymphedema of the arm. In breast cancer, we can find a lot of manifestations like dimpling or indrawing of the skin. Inside the breast, there are duct lobule stroma, and to support the stroma, the duct and the lobules, there are suspensory ligaments or the S-lace ligaments or the Cooper's ligaments, which are going from the pectoralis fascia to the skin. If there is a cancer inside the breast and it involves the Cooper's ligaments, then there will be a dimple in the skin. The overlying skin will indraw, अंदर की तरफ खींचेगी, क्योंकि कैंसर ने कूपर लिगामेंट को जकड़ लिया है, इसलिए ऊपर की स्किन पे खिंचाव पड़ के वो अंदर जाएगी. Indrawing of skin, dimpling of the skin. We can find bleeding from the nipple in breast cancer, circumferential retraction of nipple in breast cancer, and if the cancer cells, they block the superficial subdermal lymphatics of the skin, we find a pewdy orange appearance, संतरे का छिलका. And this was a recent question yesterday, right? So these can be the different presentations of cancer. How the cancer spreads? Generally, three routes. Cancer can spread locally, cancer can spread into the surrounding lymph nodes, or cancer can spread via blood. Like local spread, if suppose I say there is a cancer in the buccal mucosa and it is spreading locally, obviously it will go from mucosa to submucosa, then to the muscle layer, and then to the adventitia or the surrounding area, and then will involve the adjacent organs. So if we look at the GIT local spread, if it is a esophageal cancer, the game is starting from the mucosa. Cancer is growing in the mucosa. Then it will go to submucosa, then the muscle layer, because esophagus does not have serosa, so it will go to adventitia and then to the adjacent organs. But when we talk about stomach or maybe colon area, then the game is starting from the mucosa. After mucosa, it will go to submucosa, then to the muscle layer, then to the serosa, and then to the adjacent organs. If we look at the lymphatic spread, then if the cancer cells have to travel through lymphatic channels, then first the lymph node which is located very close to the cancer, that is going to get involved, and then the next level of lymph nodes, then the next level of lymph nodes, then the next level of lymph nodes. Like this lymphatic spread will occur. If we talk about GI cancers, foregut, midgut, hindgut, we know that lymph nodes in our body are located over the blood vessels. So if there is a foregut cancer, the principal vessel is celiac trunk. So the principal lymph node involved in foregut cancer, like stomach cancer, will be celiac lymph node. If we talk about midgut cancers, like third part of duodenum, fourth part of duodenum, jejunum, ileum, cecum, ascending proximal 2/3 of transverse colon, the principal lymph node involved will be superior mesenteric lymph node. And hindgut cancers, distal 1/3 of transverse colon, descending colon, sigmoid colon, it is the inferior mesenteric lymph node. If we look at the head and neck, then it is the cervical lymph nodes which are draining the head and neck area. The upper limb is going to the axillary lymph nodes. Breast, 80% is going to the axillary lymph nodes. Inside, like esophagus, mediastinal lymph nodes. Foregut, celiac, midgut, superior mesenteric, hindgut, inferior mesenteric lymph nodes. If we go into the pelvic area, that means inside, it can be the rectum, the bladder, the prostate. The pelvic area if we look at the anatomy, the abdominal aorta divides into two common iliac. These common iliac divide into internal iliac and external iliac. Internal iliac goes to supply the pelvic organs in the pelvis, while the external iliac becomes the femoral and goes in the lower limb. That means the pelvic organs are supplied by the internal iliac. So, cancers in the pelvic organs will be going to the internal iliac lymph nodes, whether it is bladder, prostate, or maybe the rectal area. Area which is outside here, perineum area, which include the penis, which include the anal opening area, lower limb area, all this goes to the inguinal lymph nodes. Inguinal lymph nodes. I repeat this: head and neck, cervical, upper limb, breast, axillary, inside the chest like esophagus, mediastinal, foregut, celiac, midgut, superior mesenteric, hindgut, inferior mesenteric, pelvic organs, internal iliac, perineal area in the lower limbs, that is inguinal lymph nodes. Head and neck, cervical, upper limb, breast, axillary, esophagus, mediastinal, foregut, celiac, midgut, superior mesenteric, hindgut, inferior mesenteric, pelvic organs, internal iliac, perineal area in the lower limbs, inguinal lymph nodes. Now, if we try to replicate, tell me beta, oral cancer, thyroid cancer, cervical lymph nodes, breast cancer, axillary lymph nodes, esophagus, mediastinal, stomach, celiac, cecum, superior mesenteric, sigmoid, inferior mesenteric, bladder, prostate, internal iliac, penis, anal canal, inguinal lymph nodes, lower limbs, inguinal lymph nodes. So that is how we have to correlate the lymphatics. But here, testicular lymphatics, ovarian lymphatics. Remember the the gonadal artery, it is a direct branch of abdominal aorta, whether it is testicular or ovarian. So, lymph nodes from this lymph nodes related to testis and ovary, they will not be internal iliac. They will be pre and para-aortic lymph nodes. Pre and para-aortic lymph nodes. Okay, so be careful. Testis, ovary is going to pre and para-aortic lymph nodes. Let us do it once again. Oral, cervical, thyroid, cervical, breast, axillary, esophagus, mediastinal, stomach, celiac, cecum, superior mesenteric, sigmoid, inferior mesenteric, bladder, prostate, internal iliac, penis, anal canal, inguinal lymph nodes, testis, pre and para-aortic lymph nodes. Right. Now, if we look at the blood spread, then whether the cancer will be spreading through the artery or vein. Suppose we talk about kidney cancer, then we know there is a renal artery which is supplying blood to the kidney and there is renal vein which is draining the blood from the kidney. So if there is cancer in the kidney, these cancer cells, if they have to spread through blood, they cannot go in the renal artery because direction of flow in the renal artery is towards the kidney. If the cancer cells have to go away from the kidney, they will be going in the renal vein. Now you see, right kidney cancer will be going to right renal vein, then it will be opening in the inferior vena cava, and the inferior vena cava will be going into the right atrium, right ventricle. When the cancer cells from the kidney have come into the heart is continuously beating. So cancer cells will not be able to stay in the heart. They will be going down from the right ventricle into the pulmonary artery and into the lungs. Lungs will be the area where the cancer cells will get sufficient time and space to multiply. So kidney cancer would be metastasizing to lungs. Or for that matter, you take any other cancer, suppose testicular cancer, left testicular cancer. Left testicular cancer, if it has to spread through blood, it will be going in the left testicular vein, which opens in the left renal vein, and the left renal vein goes to the inferior vena cava, and the inferior vena cava is going in the right atrium, right ventricle, pulmonary artery, lungs. Oh, So testicular cancer is also going into the lungs. Actually speaking, beta, if you look at the venous drainage, any part of the body, ultimately the venous return has to come back to the heart only, na? Either through the superior vena cava or through the inferior vena cava. That means cancer anywhere in the body, if it has to spread through blood, it will be coming to the heart, but it cannot stay in the heart, so it will be going to lungs. That is why lungs is the commonest site of metastasis for so many cancers. That is why there is a X-ray of cannonball deposits, rounded opacities in the lungs. If we look at GI cancers, midgut cancer and hindgut cancer, you know, midgut superior mesenteric vein, which joins with the splenic vein to form the portal vein. So portal vein is going into the liver. Hindgut. Inferior mesenteric vein is opening in the splenic vein, portal vein, liver. Whether it is midgut cancer or hindgut cancer, it will be going through superior or inferior mesenteric vein, portal vein into the liver. So liver becomes the commonest site of metastasis for GI cancers. And you would be surprised that 33% of colorectal cancer patients, by the time they come to the doctor, they already have liver metastasis. If the cancer is in the liver or there are metastases in the liver is also drained by hepatic veins, and these hepatic veins open in the inferior vena cava in the right atrium, right ventricle, pulmonary artery, lungs. So that is how these GI cancers via liver can go to the lungs. There are 5 cancers which commonly spread to bones, and they are remembered by a mnemonic PBKBT. पाकिस्तान भारत का बच्चा था. पाकिस्तान भारत का बच्चा था. P prostate, B breast, K kidney, B bronchus, T thyroid. The commonest cancer going to bones in males is prostate cancer. Commonest cancer going to bones in females is breast cancer. And whether it is a prostate cancer or breast cancer, these cancers, they travel through a Batson's lumbar vertebral plexus of veins into the lumbar vertebra. However, it can go in the femur, thoracic vertebra, rib, skull, and so on, but commonly lumbar vertebra through Batson's lumbar vertebral plexus of veins. So we discussed about the local spread, the lymphatic spread, and the blood spread. In stomach cancer, we'll be talking about a direct peritoneal spread. If there is a cancer in the stomach, cancer cells can break from the stomach and they can spill here and there in the peritoneal cavity. If there are tumor deposits on the peritoneal surface, that is called as peritoneal seedlings. If there are periumbilical tumor deposits, that is Sister Mary Joseph nodule. If there are tumor deposits on the functional ovary, that is Krukenberg tumor, and tumor deposits on the anterior rectal wall is Blummer's shelf. All these can be seen in stomach cancer. So till now what we discussed about the type of cancer, site of cancer, risk factors, how the cancer grows, how the patient presents, and how these cancers can spread. Now based on how the patient comes to us, we'll approach the patient accordingly. Suppose any patient comes to us with jaundice, we know the first investigation will be LFT and then we'll be doing ultrasound. Any patients who come to us with the abdominal mass, abdominal lump, abdominal swelling, the first investigation will be ultrasound, and then based on ultrasound, we'll proceed further. If there is something in the liver parenchyma or splenic parenchyma or kidney parenchyma, we can do a CCT. If there is something in the biliary channel or pancreatic channel, we can do MRCP or maybe ERCP, like that. Let us see all these cancers one by one, how to play the game. Oral cancer patient, now beta, now don't think that you are studying. Just think that right now you are wearing that prestigious white coat and the stethoscope, and you are actually sitting in the hospital wearing that prestigious white coat and the stethoscope, right? You are sitting in the OPD in the hospital. Now, oral cancer patient comes to you with a growth here, you can simply take a biopsy. If patient comes to you with dysphagia, you can do a barium swallow. If it is esophageal cancer, you will find a filling defect and a rat tail appearance. If you are suspecting esophageal cancer, then you will do endoscopy and you can take a biopsy from this tumor. If a patient presents with epigastric mass, first you will do ultrasound, and if on ultrasound you see there is a tumor type thing in the stomach, you will do upper GI endoscopy and take a biopsy from the stomach tumor. If suppose this stomach cancer patient comes to you with melena, black tarry stools, then first you will have to examine this stool, whether it is palak or it is blood, stool for occult blood. If that is positive and it is melena beta, it is not red, it is black, and if it is black, it is not from lower GI, it is from upper GI. That means अगर किसी की काली काली पॉटी आ रही है और आपने स्टूल टेस्ट करके पता लगा लिया कि भाई इसमें तो आरबीसी है, तो एंडोस्कोप नीचे से नहीं ऊपर से डालेंगे. काली है, नीचे से कुछ नहीं मिलेगा, ऊपर से. So if it is melena, please be careful. It's not lower GI endoscopy, it's not colonoscopy, it will be upper GI endoscopy, and then you can find the tumor. If it is bleeding per rectum, then obviously if it is red, then you will do a colonoscopy and you can identify. And it should be a complete colonoscopy. You have to screen the entire colon, because many times this has happened that when you are doing colonoscopy, you find a growth in the sigmoid colon, you take a biopsy and you think the job is done. But no, there might be a growth in the sigmoid, there might be other growths in other parts of the colon also. So it's a complete whole colonoscopy which has to be done. If there is a growth at the anal verge, you are able to see that cancerous growth right in front of you, you can take a direct biopsy, just like an oral cancer. For gallbladder cancers, if there is a right hypochondrial mass, first you do ultrasound, and if on ultrasound you feel that you see that there is tumor in the gallbladder, then there is no endoscope which can be passed inside the gallbladder. Because if you are trying to do ERCP, through ERCP you are going into the duodenum, you can simply pass some instrument in the CBD, but because the diameter of cystic duct is only 1 to 3 millimeter, you cannot pass this instrument in the gallbladder. That means if on ultrasound there is tumor in the gallbladder, we cannot pass any endoscope and take a biopsy from this endoscopically. If you have to take a biopsy, then under ultrasound CT guidance, you might be thinking that I should do a percutaneous biopsy. But अगर अपन ऊपर से needle अंदर डाल रहे हैं, if we are making a percutaneous biopsy, when you are coming back, you might spill the cancer cells in the peritoneal cavity and you will spread the cancer in the peritoneal cavity. So percutaneous biopsies are contraindicated. They are done only in those situations where the cancer has already spread and the patient is going to die. Before the patient dies, at least we can make a diagnosis that okay, he was dying because he had this cancer. But generally, that is also not indicated. So if we cannot take a percutaneous biopsy, then better than ultrasound would be CECT. So CECT becomes the investigation of choice in gallbladder cancers. Pancreatic cancers, if the patient presents with jaundice, first we do LFT, then we do ultrasound. If on ultrasound we find there is a tumor in the head of the pancreas, then we do CECT, because again we cannot take a percutaneous biopsy. If there is a tumor in the periampullary region, that means close to the ampulla, we can do ERCP and biopsy. Same problem comes in the kidney also. If there is a cancer in the outer portion of the kidney, patient is presenting with painless hematuria. Whether it is kidney cancer or bladder cancer, there is painless hematuria. First, you have to do urine examination for malignant cells. If there are malignant cells in urine, It can be a bladder cancer or a kidney cancer. And as all the great doctors watching this session can understand, bladder cancer will be much more common than kidney cancer. So if you are suspecting bladder cancer, you put a cystoscope in the bladder. But if you don't find tumor in the bladder, then you feel that this would be a kidney cancer. And because we cannot do a percutaneous biopsy, so it's better to get a CECT done. While for bladder cancers, yes, if it was a painless hematuria, urine shows malignant cells, then you do a cystoscopy, you find a tumor in the bladder, take a biopsy. Prostate cancers, we do a transrectal prostatic biopsy, transrectal ultrasound guided prostatic biopsy. Penile cancer, just like oral cancer, anal cancer, penile cancer, direct biopsy. Testicular cancer, scrotal enlargement. Imagine 30-year-old gentleman in your OPD with scrotal enlargement. You switch off the lights in the OPD. Patient is on the examination couch. You try to throw the light from one side, transillumination. If it is tumor, transillumination will be negative. Will you put a needle? Never. Because again, there is risk of spillage of cancer cells in the scrotum. Better to do ultrasound. If ultrasound shows there is a tumor in the testis, you do a CECT and you can take the help of tumor markers as well. Neck swelling, you do ultrasound and ultrasound guided FNAC. Breast lump, any breast lump after 25 years of age, standard guidelines, triple assessment, CRP, clinical, radiological, pathological. Once we have done these stepwise investigations, now comes the question, what should be the investigation of choice to diagnose the cancer, then to stage the cancer, then for distant metastasis. When the question is, what is the investigation of choice to diagnose the cancer? So beta, for diagnosis, biopsy will be the best. शरीर में अगर किसी जगह से बायोप्सी ली जा सकती है बिना कैंसर को फैलाए, तो बायोप्सी से अच्छा कोई इन्वेस्टिगेशन नहीं हो सकता ये प्रूव करने के लिए कि ये कैंसर है. And those areas, I repeat this in English, any area in the body from where biopsy can be taken without risk of spillage of cancer here and there, then biopsy will be the best investigation to prove or to diagnose that it is cancer. If by chance biopsy cannot be taken, then CECT, right? Any cancer which is on the exposed area in the body, you can easily take a biopsy without spilling the cancer. Any area in the body where you can pass an endoscope, you can take an endoscopic biopsy. But those areas where you cannot take direct biopsies or you cannot do endoscopic biopsies, there we go for CECT. Prostate cancer, we do a transrectal prostatic biopsy. Right? Now, if we have this concept and if suppose there is a question in front of you, 17th of January, what is the investigation of choice to diagnose the cancer? Oral cancer. Beta, you have only two options, biopsy and CECT. Oral, biopsy. Esophagus, biopsy. Stomach, biopsy. Colorectal, biopsy. Anal, biopsy. Gallbladder, CECT. Head pancreas, CECT. Periampullary, biopsy. Kidney, CECT. Bladder, biopsy. Prostate, biopsy. Penis, biopsy. Testis, CECT. Thyroid, FNAC or biopsy. Breast, biopsy. Oral, biopsy. Esophagus, biopsy. Stomach, biopsy. Colorectal, biopsy. Anal, biopsy. Gallbladder, CECT, head pancreas, CECT, periampullary biopsy, kidney, CECT, bladder biopsy, prostate biopsy, penis biopsy, testis, CECT, thyroid FNAC, breast biopsy. Just imagine an entire GIT. एंडोस्कोप या तो ऊपर से जाएगा या नीचे से जाएगा. अगर ऊपर से जाएगा तो ये सेकंड पार्ट ऑफ ड्यूडनम तक जा सकता है. नीचे से जाएगा तो ये एनल, रेक्टम, सिग्मोइड, डिसेंडिंग, ट्रांसवर्स, असेंडिंग, सीकम तक जाएगा. बचा क्या? थर्ड पार्ट ऑफ ड्यूडनम, फोर्थ पार्ट ऑफ ड्यूडनम, जेजुनम, आइलियम. यहाँ एंडोस्कोप नहीं जाएगा. तो अगर कैंसर इस इलाके में होता, थर्ड फोर्थ पार्ट ऑफ ड्यूडनम, जेजुनम, आइलियम, देन द आंसर वुड हैव बीन CECT. लेकिन इस इलाके में कैंसर नहीं होता, इसलिए जनरली नहीं होता, तो इसलिए पूरे GI रास्ते का इन्वेस्टिगेशन ऑफ चॉइस टू डायग्नोज द कैंसर इज बायोप्सी. गॉल ब्लैडर में एंडोस्कोप नहीं जाता, CECT. हेड पैनक्रियाज में नहीं जाता, CECT. लेकिन पेरीएम्पुलरी में ERCP बायोप्सी. किडनी में अगर एंडोस्कोपी करनी है तो यू पास एंडोस्कोप थ्रू द यूरेथ्रा, ब्लैडर, यूरेटर, पेल्विक एलिशियल सिस्टम तक जाएगा, लेकिन आउटर पोर्शन ऑफ द किडनी में नहीं जाएगा. तो किडनी कैंसर PCT, प्रॉक्सिमल कन्वोल्यूटेड ट्यूब्यूल, नेफ्रॉन से अराइज होता है, CECT. राइट बेटा? वंस अगेन, व्हाट इज द इन्वेस्टिगेशन ऑफ चॉइस टू डायग्नोज अ कैंसर? ओरल बायोप्सी, ईसोफेगस बायोप्सी, स्टमक biopsy, colorectal biopsy, anal biopsy, gallbladder, CECT, head pancreas, CECT, periampullary biopsy, kidney, CECT, bladder biopsy, prostate biopsy, penis biopsy, testis, CECT, thyroid FNAC, breast biopsy. Wonderful. Now, what is the investigation of choice to stage the cancer for local staging? मतलब कैंसर लोकली कितना फैला हुआ है. सो वी हैव गॉट आइदर CECT और MRI. All the areas in the body where there are nerves, vessels, muscles. You remember that fistula in ano? How anal sphincter muscles? MRI. Nerve, vessel, muscle, MRI. Parenchyma, CECT. Okay? Head and neck area, there are lot of muscles. So for staging, MRI. Breast के पीछे क्या है? Pectoralis major, pectoralis minor, muscles. What is there behind the breast? Muscles. So breast के लिए भी MRI. Pelvic area, there are lot of muscles. So for staging of cancer in the pelvic area, we'll be doing MRI. Right? टेस्टिस के लिए वी हैव टू सी प्री-पैरायोटिक लिम्फ नोड्स, सो इट इज नॉट MRI. छाती के लिए, पेट के लिए CECT. I repeat once again, for the head and neck and for the pelvic area, because there are a lot of muscles, we do MRI, but chest and abdomen we are doing CECT. Breast is MRI because of the muscles. Testis is CECT because of pre-parayotic lymph nodes. I repeat this one more time. The head and neck area and the pelvic area full of muscles, we are doing MRI. The chest and the abdomen, we are doing CECT. Breast, we are doing MRI. Testis, we are doing CECT. Okay, let's try. Staging investigation of choice. Oral, MRI. Thyroid, MRI. Breast, MRI. Esophagus, CECT. Stomach, CECT. Gallbladder, CECT. Pancreas, CECT. Kidney, CECT. Cecum, CECT. Descending colon, CECT. Bladder, prostate, rectum, anal canal, penis, MRI. Testis, CECT. Oral, MRI. Thyroid, MRI. Breast, MRI. Esophagus, CECT. Stomach, CECT. Gallbladder, CECT. Pancreas, CECT. Kidney, CECT. Cecum, CECT. Descending colon, CECT. Bladder, prostate, rectum, anal canal, penis, MRI. Testis, CECT. Oral MRI, thyroid MRI, breast MRI, esophagus CECT, stomach CECT, gallbladder CECT, pancreas CECT, kidney CECT, cecum CECT, sigmoid colon, descending colon CECT, bladder, prostate, rectum, anal canal, penis MRI, testis CECT. Now you tell me, beta, staging investigation of choice: oral, thyroid, breast, esophagus, stomach, gallbladder, pancreas, kidney, cecum, sigmoid, bladder, prostate, rectum, anal canal, penis, testis, CECT. Oral, thyroid, breast, esophagus, stomach, gallbladder, pancreas, kidney, cecum, descending sigmoid, bladder, prostate, rectum, anal canal, penis, testis, and very good. If we talk about investigation of choice for distant metastasis, then we have only one investigation, that is PET scan, positron emission tomography. In this, we give a isotope 18-FFDG, 18-fluorine fluorodeoxyglucose, which has a half-life of 120 minutes. This is glucose. Wherever there is mitotic activity in the body, that means those rapidly dividing mitotic cells will be requiring more glucose. If you are giving glucose, this glucose will be taken up by those mitotic cells, and when we do a whole body CT scan, those mitotic areas look as golden shadows. So wherever we find golden shadows in the body, we can say, yes, this is the area for mitotic activity. In GI cancers, for depth of the tumor, that is whether the tumor is only in the mucosa or going into the submucosa or muscle, we do endoscopic ultrasound. That means for esophageal stomach cancers, we can do endoscopic ultrasound from above. If it is a colorectal cancer, we can do endoscopic ultrasound from below to know the depth of the tumor. So these are the all investigations what we do. Once again, if I try to ask you these questions, what is the investigation of choice to diagnose a cancer? Diagnosis. Answers can be either biopsy or CECT. In thyroid, we'll do FNAC. Okay. So only two options are there: biopsy, CECT, right? Oral, esophagus, stomach, colorectal, anal, gallbladder, head of pancreas, periampullary, kidney, bladder, prostate, penis, testis, no biopsy, thyroid, breast, wonderful. Staging investigation of choice: oral, thyroid, breast, esophagus, stomach, gallbladder, pancreas, kidney, colon, bladder, prostate, rectum, anal canal, penis, testis. And for metastasis and for depth of tumor in GI cancers, wonderful. So this is regarding the investigation story. Now we have completed all the investigations. We know that we are fighting with a cancer, and this cancer is involving these many areas. Based on this, we can do a staging. And general staging, what we use is a TNM staging. In this TNM staging, first we'll talk about esophagus, stomach and colon, and then we'll be talking about testis and breast. T is for tumor, N is for lymph node, M is for metastasis. First, let us see the T. Whether it is esophagus, stomach or the colon, the cancer is originating from the mucosa. That means when we start doing the TNM staging, that is T1, we will say when the cancer has gone into the submucosa, that is T1. Whether it is esophagus, stomach or the colon, T1 will be submucosa. When the cancer goes into the muscle, that will be T2. Esophagus, stomach, colon. T2 is muscle. T3, when it goes beyond the muscle, in the esophagus there is no serosa, there is adventitia. So T3 in the esophagus will be adventitia. T3 in the stomach should ideally be serosa, but T3 here is reaching into the serosa, or subserosa. अभी serosa को breach नहीं किया है, it is just reaching the serosa. So subserosa, T3 in the stomach is subserosa, but T4A will be penetrate the serosa or perforate the serosa. I repeat beta, T1 mucosa, once again, T1 is submucosa, T2 is muscle, T3 in the esophagus is adventitia, T3 in the stomach is subserosa, T3 in the colon is also subserosa, T4 esophagus adjacent organs, T4 in the stomach is T4A and T4B. T4A is perforate the serosa and T4B is adjacent organs. T4 in the colon is adjacent organs. Okay, so T1, T1, T1 same, T2, T2, T2 same, T3 adventitia, T3 subserosa, T3 subserosa, T4 adjacent organs, T4A perforate the serosa, T4B adjacent organs, T4 adjacent organs. Let's do T stage for esophagus. Submucosa, muscle, adventitia, adjacent organs. Submucosa, muscle, adventitia, adjacent organs. Stomach. Submucosa, muscle, subserosa, perforate the serosa, adjacent organs. Colon. Submucosa, muscle, subserosa, adjacent organs. In the esophagus, T4 can be divided into T4A and T4B. If solid organs are involved like trachea, bone, aorta, then it is T4A. When membrane type of structures are involved like pleura, pericardium, diaphragm, that is T4A. And when solid areas are involved like trachea, bone, aorta, that is T4B. Right. Once again, if we do the T staging, submucosa, muscle, adventitia, adjacent organ, pleura, pericardium, diaphragm, trachea, bone, aorta. Stomach. Submucosa, muscle, subserosa, perforate the serosa, adjacent organs. Colon. Submucosa, muscle, subserosa, adjacent organs. Submucosa, muscle, adventitia, adjacent organs, pleura, pericardium, diaphragm, trachea, bone, aorta. Submucosa, muscle, subserosa, perforate the serosa, adjacent organs. Submucosa, muscle, subserosa, adjacent organs. Submucosa, muscle, adventitia, adjacent organs, pleura, pericardium, diaphragm, trachea, bone, aorta. Submucosa, muscle, subserosa, perforate the serosa, adjacent organs. Submucosa, muscle, subserosa, adjacent organs. So this is the T staging for esophagus, stomach and colon. Now lymph node staging. Lymph node staging in GIT is according to the number of lymph nodes. For example, N1, N2, N3. Stomach also N1, N2, N3. But in colon, N1 and N2. Now what is this N1, N2, N3? 1 to 2, 3 to 6, 7 or more than 7. 1 to 2 group of lymph nodes, 3 to 6 group of lymph nodes, 7 or more than 7 group of lymph nodes. 1 to 2, 3 to 6, 7 or more than 7. Stomach also same, 1 to 2, 3 to 6, 7 or more than 7. However, N3 in stomach can be A and B, 7 to 15, more than 15. In colon, there are only two, N1 and N2, and there is a slight change. It is not 1 to 2, it is 1 to 3 and 4 or more than 4. Okay. Now let's try this. 1 to 2, 3 to 6, 7 or more than 7. 1 to 2, 3 to 6, 7 or more than 7, 7 to 15, more than 15. 1 to 3, 4 or more than 4. 1 to 2, 3 to 6, 7 or more than 7. 1 to 2, 3 to 6, 7 or more than 7, 7 to 15, more than 15. 1 to 3, 4 or more than 4. And M1 is distant metastasis. If I summarize the complete TNM staging individually, for esophagus, submucosa, muscle, adventitia, adjacent organs, pleura, pericardium, diaphragm, trachea, bone, aorta, 1 to 2, 3 to 6, 7 or more than 7, metastasis. Stomach, submucosa, muscle, subserosa, perforate the serosa, adjacent organs, 1 to 2, 3 to 6, 7 or more than 7, 7 to 15, more than 15, metastasis. Colon, submucosa, muscle, subserosa, adjacent organs, 1 to 3, 4 or more than 4, metastasis. So this is the TNM staging. Now, if we look at the testicular cancer, then not the TNM, but there is the stage 1, stage 2, stage 3, stage 4. Stage 1 is when the cancer is confined to the testis only. Stage 2, when the cancer has gone into the lymph nodes below the diaphragm. Stage 3, lymph nodes above the diaphragm. And stage 4, metastasis. 1, testis, 2, lymph nodes, 3, lymph nodes, 4, metastasis. 2 lymph nodes below the diaphragm, 3 lymph nodes above the diaphragm. 1 testis, 2 lymph nodes, 3 lymph nodes, 4 metastasis. 2 lymph nodes below the diaphragm, 3 lymph nodes above the diaphragm. Lymph nodes below the diaphragm can further be classified as A, B, C. Up to 2 centimeters, more than 2 to 5 centimeters, and more than 5 centimeters. T2A up to 2 centimeter, T2B more than 2 to 5 centimeter, and T2C is more than 5 centimeters. Testis, lymph node below the diaphragm, lymph node above the diaphragm, metastasis. Stage 1, stage 2, stage 3, stage 4. Stage 2, T2A up to 2 centimeter lymph nodes, 2B more than 2 to 5 centimeter lymph nodes, and T2C or stage 2C, that is more than 5 centimeter. Right. Now breast cancer staging. Again TNM staging in breast cancer, where T is something related to size of the cancer, size of the tumor. And lymph node, it is which level of lymph node is getting involved. Right? Whether it is axillary or internal memory or like that. And metastasis is metastasis. So if we look at the T stage, there is T1, T2, T3, T4. Up to 2 centimeters is T1, more than 2 to 5 centimeters is T2, more than 5 centimeters is T3. And T4 is, it can be any size, but if the cancer has gone into the chest wall, that is ribs and intercostal muscles, then it is T4A. If the breast cancer has gone anteriorly into the skin like pudgy orange, then it is T4B. If the cancer is going into the chest wall plus skin involvement, then it is T4C. And if it is an inflammatory type, red, then it is T4D. Okay, so let's do the T staging first in breast cancer. 2 to 5, more than 5, any size. 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 T1, T2, T3, T4. Now T4 is any size. If it is going into the chest wall, skin, both inflammatory. If it is going into the chest wall, it is T4A. Going into the skin, T4B. Both chest wall and skin, T4C. and inflammatory T4D. Let's do it once again. 2, 2 to 5, more than 5, any size. Chest, skin, both inflammatory. 2, 2 to 5, more than 5, any size. Chest, skin, both inflammatory. 2, 2 to 5, more than 5, any size. Chest, skin, both inflammatory. Right? Now, lymph node staging in breast cancer. It is for the ipsilateral lymph nodes only. That means if it is a right breast cancer, then whatever lymph nodes are involved on the right side, that is the lymph node staging. If there is a right breast cancer and suppose left axillary lymph nodes are involved, it is not a lymphatic spread. The cancer would have gone into the blood, and through blood the cancer has gone into the opposite axilla. So only ipsilateral lymph nodes are classified in lymph node staging. Contralateral lymph nodes or bilateral lymph node involvement indicates metastasis M1. Okay. So let's look at the ipsilateral lymph nodes, and broadly we know there are axillary lymph nodes, there are internal mammary lymph nodes, and there is one supraclavicular lymph node. Okay. In breast cancer, there is N1, N2, N3. N1 में एक है, N2 में there are two, N2A and N2B, and N3 में there are three, N3A, N3B, N3C. Okay, let's do it. Mobile, fixed, internal memory. If there are mobile axillary lymph nodes, it is N1. Fixed axillary lymph nodes, N2A. Internal memory lymph nodes, N2B. If there are axillary plus apical lymph nodes, that is infraclavicular lymph nodes, axillary plus apical, this is N3A. Axillary plus internal memory lymph nodes involved, both axillary and internal memory involved, this is N3B. And supraclavicular lymph nodes is N3C. Let's try it. Mobile, fixed, internal memory, axillary plus apical, axillary plus internal memory, supraclavicular. Mobile, fixed, internal memory, axillary plus apical, axillary plus internal memory, supraclavicular. Mobile, fixed, internal memory, axillary plus apical, axillary plus internal memory, supraclavicular. And M is metastasis. So that is how we can do the staging of these different cancers. Once the staging is done, we come to know that yes, this is a cancer and this is how far the cancer has spread. So now we have to treat the cancer. And for treatment beta, we have got either a curative treatment or a palliative treatment. If the patient comes to an early stage, then we can give various treatment options and destroy the cancer completely in this patient, so that patient can be permanently cured of this cancer. That is curative. But if the patient comes to us at a very advanced stage, suppose there was a cancer in the breast which has gone into the brain, lungs, liver, bones, everywhere, we will not be able to destroy all the cancer in this lady. So, whatever life this lady is left with, we will do some palliative treatment to make that life as comfortable as possible. That is not curative, that is just palliative. कैंसर का नाम सुन के डर क्यों लगता है? Why we are scared of cancer? Problem is, cancer patient does not come to us at early stage. By the patient presents to the doctor, the cancer is already advanced. And if it is already advanced, metastatic, then it becomes very difficult to remove this cancer from the patient body. And that is why whatever life the patient is left with, to make that life as comfortable as possible, we just give that palliative treatment. My dear great doctors, to cure the patient, we have got 5 wonderful options depending on the stage. Best is surgery. You have to remove the cancer along with a nice margin. Don't leave any cancer behind in the patient. That is the best treatment. However, we can give chemotherapy, that is cytotoxic drugs, but this chemotherapy, my dear great doctors, is not only going to destroy the cancer cells, but it will also destroy the normal cells. That is why we see a lot of side effects of chemotherapy. So the doctor has to weigh the pros and cons before giving chemotherapy. If the advantage is more, then go for chemotherapy. Radiotherapy is a local control method. For example, if there is a cancer in the breast, we can give radiotherapy and destroy these cancer cells. Hormonal therapy will be indicated in those cancers only which have got a hormonal etiology, like breast cancer, estrogen game, prostate cancer, androgen game. So we can give hormonal therapy in breast cancer and prostate cancer. Like in breast cancer, we give anti-estrogens tamoxifen in a premenopausal female and anastrozole in postmenopausal female. While prostate cancer, we give anti-androgens, LHRH agonist, antagonist, testosterone receptor blockers, androgen receptor blockers, testosterone production blockers, and so on. We can also remove both the testes in prostate cancer patients to reduce the androgen source. And nowadays, because of so many advances are going on, especially at the molecular level, genetic level, especially in cancers, so we can identify which growth factor is actually responsible for rapid multiplication or mitotic activity of the cells. And we can give targeted therapy against those factors so that the growth does not occur. For example, HER2/neu gene, we have got a therapy against HER2/neu gene. If HER2/neu gene is positive, whether it's a breast cancer or stomach cancer, we can give trastuzumab or pertuzumab and stop this cancer. So these are different methods to fight against cancer. Lastly, prognosis. What is the future of any cancer? Prognosis depends on the stage of the cancer. At what stage the patient has come to the doctor. That means stage means TNM. And in this TNM, if we have to choose one, it is the lymph node status, which is the most important for deciding the future prognosis. Thank you very much for your patience. We'll take a break here, 15-20 minutes break. We'll be back. It's at almost 3. What's the time? 3:55 p.m. We'll be back at 3:55 p.m. Thank you very much. I'll just put it